We're getting started?
Yes.
Perfect. So welcome everyone to IBD Academy, and we continue our successful format with a lot of experts from your region to talk about complicated cases. And we are grateful that Ben Cohen and I that we can be part of this program led by Professor Sharara and his team. And Dr. Cohen unfortunately sends his regrets. He will be available in the chat box, but he has laryngitis today, so he has a hard time speaking. And so I have the pleasure to moderate for you. We start with a case with ulcerative colitis, and then we move on to a case with Crohn's disease, and then we'll discuss it with the faculty. And I see Dr. Kotubi, Dr. Mogawer, and others I'm sure will join. So I would hand the microphone over to Dr. Al-Bawardi, who will talk about a complicated case with ulcerative colitis.
Okay, good evening, everyone. And I want to first start by thanking Dr. Sharara and the moderators, Flo and Ben, for giving me the opportunity to present this case for you. This is a case of an acute, severe PSC-associated IBD. So this is a 36-year-old man with no significant past medical history. He initially presented in January of 2022 with about a 5-year history of on and off bloody diarrhea and abdominal pain. He never sought care until January of 2022, where he was evaluated locally and underwent a colonoscopy and was shown to have pan-ulcerative colitis. Pathology slides could not be obtained, but we did have the pathology report that confirmed chronic active inflammation. Post his diagnosis, he also underwent an MR enterography, which did show evidence of pancolonic inflammation with what was described as backwash ileitis, as well as intrahepatic biliary dilatation consistent with PSC. He was started on oral mesalamine with some partial response, and his follow-up was sporadic with his local gastroenterologist for the next year. He initially presented to us in January of 2023, and when he presented to the outpatient clinic, he was quite sick. He was tachycardic with a heart rate of 110. He was also malnourished with a BMI of 18.7. He actually came to the clinic in a wheelchair due to generalized weakness and fatigue. So he described more than 15 bloody bowel movements per day, and this change in clinical status happened for the past maybe 3 to 4 weeks prior to presentation. So we immediately hospitalized the patient, and on hospitalization, his initial CRP was 128, his albumin was 2.7, hemoglobin was 9, and the alkaline phosphatase was 259. His other liver tests were completely normal. Stool infectious studies, including C. diff, were negative. A CMV viral PCR was 260. His chest X-ray was normal, and his quantiferon was negative. So these are a couple of images from a CT enterography that was obtained on admission. And as you can see, the colon seems featureless, or the colon wall seems featureless or ahostral, with thickening of the wall of the colon, along with some enhancement and mild dilatation. He also underwent an MRCP, which confirmed intrahepatic biliary ductal dilatation and narrowing without a dominant stricture, consistent with PSC. So this is his initial flexible sigmoidoscopy on presentation. And these are representative images of the rectum. You can see some pseudopolyps on one area of the image. On the right side of the image, you can see a large deep ulcer. And the flexible sigmoidoscopy was extended up to the sigmoid, where there was large circumferential ulcerations, as shown in these two images. And this is the extent of the scope up to the probably proximal sigmoid. The patient was started on IV methylprednisolone 60 milligrams per day. Colorectal surgery was consulted and evaluated the patient on admission. His colon biopsies eventually returned positive for CMV. This was based on high density of cells on immunohistochemistry, and he was started on IV ganciclovir in addition to the corticosteroids. So on repeat evaluation, day 4 to 5, the patient continued to have up to 8 to 10 bowel movements a day. Although his CRP marginally improved, it went down to 99 from 125, and his albumin remained low at 2.6. So we have a patient with acute severe UC in the background of PSC. So I wanted to pose a few questions to the attendees and the audience and the moderators regarding your current management of acute severe UC. So in your practice, what is your usual preferred medical rescue therapy? What are some things that influence your decision? And if you do use infliximab, how do you usually use it? What dose and what frequency? If you do use cyclosporin, do you use any JAK inhibitors? And if so, what formulation and dose? And then going back to JAK inhibitors, thinking about in general in acute severe UC, should we position JAK inhibitors early in the treatment? And then finally, any role of JAK inhibitors post-infliximab failure in acute severe UC?
Dr. Al-Babardi, excellent questions and also a very clear presentation of a patient that we see in our daily practice. Bit more complicated with the PSC, which I think will also be a very good discussion to have regarding the medications. But before we dive into the true meat, which is how do we treat this patient, I want to pose a couple of questions about the case to our panel. And I'm going to, in fact, start with Dr. Al-Sharara before I will ask Dr. Natut about the role of imaging in acute severe ulcerative colitis. But my question, Dr. Sharara, is the patient has reported to have had backwash ileitis, and it's acute severe UC. We're thinking about surgery. This patient at the moment does not want to have surgery, but the surgeons are involved. Do we need to worry about this? Could this be Crohn's disease? How do you define ulcerative colitis, backwash ileitis, because it may affect your surgical plan?
Yeah, I mean, that's a very good question. And there are certainly some patients who present with, for all practical purposes, everything suggests ulcerative colitis, but then even a few years later, it turned out to have Crohn's disease, or on resection, you find that they have granulomas or they have Crohn's disease as involving their colon. So I think the presence of backwash ileitis does raise a little bit of a red flag, but generally, such a patient, if that patient is going to get to surgery, is going to have a 3-stage procedure anyway. So I think at that point, then a decision can be made later on what would be the proper treatment to follow. But yeah, it is something to keep in mind, and that might complicate the post-operative course in those patients. Yes.
Mm-hmm. And Dr. Al-Babardi, how would you separate the two?
I mean, for this case, I think it's a little different because he does have a background of PSC, and we know they might have a distinct phenotype from the typical Crohn's or UC. So they tend to have rectal sparing or relative rectal sparing. As you saw from these images, part of the rectum actually looked kind of okay with some just inflammatory pseudopolyps. They tend to have worse inflammation on the right side compared to the left side, and they do tend to have ileal involvement, or what we're calling backwash ileitis. So I think with PSC, he actually kind of fits the typical phenotype we see with PSC IBD. But I do agree with Dr. Haddad that, if he does undergo surgery, we do have, it's going to be a stage surgery, so we'll have pathology to help us kind of make a distinguishing between Crohn's or UC. But in general, if this is not a PSC patient, I think I would look into the distance in which the terminal ileum is involved, if it's the last 5 to 8 centimeters only. And then if I do see like frank large ulcerations, it makes me think that this is less likely backwash ileitis, but more of typical ileal involvement.
Yeah, and I agree very much with you. The PS is a classical PSC phenotype, and Dr. Cohen just pointed out the classical patulous IC valve that you saw in the images is also you can find in PSC. Interestingly, backwash ileitis can be seen on imaging, like in your case, and people may be afraid of Crohn's disease. My feeling tells exactly what Dr. Sharara said and what Dr. Albawardi said. I do think this patient has ulcerative colitis with a PSC phenotype because he fulfills multiple of those criteria. We sometimes use histology, where we find active changes more than chronicity in backwash ileitis, and then if you have deep serpiginous ulcers, obviously would point more towards Crohn's disease. So very good points. I'm gonna now ask Dr. Natout before I go back to the panel for the next steps in therapy. What's the role of imaging in acute severe ulcerative colitis?
Yeah, thank you for the question. So if we go into imaging, the expected appearance of ulcerative colitis is the featureless colon, which Dr. Albawardi just showed. We look for the loss of the hostile pattern. We look for continuous involvement, with involvement, of course, of the rectum and going backward to involve most of the colon. And in severe cases, as we might also see, the whole colon being involved with sometimes backwash ileitis, sometimes no involvement of the ileum. To compare it to Crohn, in Crohn's disease, in most of the cases, we'll see the typical terminal or distal ileitis with possible minimal inflammatory changes in the proximal colon. However, this extensive appearance that we saw, radiologically speaking, it might be reported straightforward as ulcerative colitis, severe flare, severe form, rather than discussing the possibility of any Crohn's disease, given that the appearance in the terminal ileum might not radiologically appear as typical for ulcerative colitis. The usual expected appearance is the stratified or trilaminar enhancement with areas of inner wall hyperenhancement, ulcerations, pseudocirculation, strictures, or even in the fistulizing form where we might see the tethering of bowel loops and interloop fistulas, which are, of course, classic for Crohn. So in the images Dr. Albawardi showed, it goes with ulcerative colitis severe form.
Yes, and I agree completely with you. And you may be able to obviously detect toxic megacolon when the patient needs to go to the surgeon directly, contain perforations, open perforations. And we personally do still KUBs. We don't do routinely CT enterographies unless we have a suspicion for perforation or any extraluminal process. To rule out megacolon, and we do that if patient comes in acutely, in fact, daily, until the patient declares herself or himself. So now we come to the meat of the case, and in fact, I start with Dr. Kotoubi. Let's assume the patient would not have PSC. If you can run us through your rationale, infliximab, cyclosporin, JAK inhibitor, and then I will ask Dr. Mogawer afterwards, does PSC affect your choice of therapy? But we start with Dr. Kotoubi, please.
Thank you, Florian, and welcome. Good to see you all. Now, I'm just going to go back to the pictures. When I saw the pictures, I thought, come on, doesn't look like a UC. But when you added because that big ulcers actually look like Crohn, but when you added the CMV piece, I thought, no, okay, now this is a different issue. And when we saw the pictures of the X-ray of the colon, that typical fit the pictures of the UC. Now with the treatment, now frankly speaking, I treated before some patient with cyclosporin, they did well, but the data showed infliximab is as good as cyclosporin. So I had few patients also treated with infliximab for the acute exacerbation with ulcerative colitis. So my first choice would be infliximab. Usually I go high dose 10 milligram per kilos as a rescue therapy. If patient does not improve, then usually we have to go for surgery. Now with the JAK, there's some data on the TOFA that it work on the acute ulcerative colitis, but frankly, I have not used it yet. I have not used any JAK for acute ulcerative colitis. My main choice here will be the infliximab.
Infliximab. Okay, so 10 milligrams per kilogram. And then you said if patient doesn't improve, we'll go to surgery. what means improvement for you?
Well, within 48 hours, usually, or 72 hours, if it's not improving, his CRP does not improve, the diarrhea is not improving, the CRP is still elevated, I think there's no chance to rescue the colon.
Mm-hmm. And then what would you expect as a drop in CRP to be comfortable and say this is working?
Well, if the patient is on the also on the steroids, we expected within 48 hours to have, at least some improvement. Also with the distension, with the pain, we look at all the parameters, not only the CRP. We look at the colon, whether the distension is better. So it is multiple things we look at before we decide to send him to surgery. But surgery should be always on the case.
I agree completely with close surgical involvement. As a rule of thumb, I personally use a drop in CRP by half by day 3 as a ballpark criterion. Obviously, you have to see the patient as a whole. I noted when going by bowel movement, often the patients have so much pain they stop eating, and then their bowel movement frequency goes down, and they actually get worse because they don't eat. The bowel movement goes down, and the CRP stays high. So I actually follow surrogates quite closely. But this is a very good discussion, Dr. Kotubi. So Dr. Mogawer, what about all these therapies in a patient with PAC? Does that matter, or would you consider PAC in your decision making?
Well, it's my honor to be with you today. I'm really appreciating this meeting, and I like so much being one of the members. And I would also thank Dr. Bedri for this nice presentation. And of course, Florian, for your moderation for this, and all of the team, of course. Well, in such a case, I think in our country specifically, we don't have IV cyclosporin. And the choice to use is always infliximab after starting the dose of steroid. We usually evaluate the condition, and by day 3, if we don't have a response, we go to infliximab. And we follow the patient for 3 more days, and then at that time would be the decision if surgery would be indicated or not. Of course, JAK inhibitors are known to have a fast onset of action, and they could be used, especially, for example, TOFA, which we have already in our country. Maybe this will be a second choice, but we don't have a lot of data or guidelines telling us that we can use. So I personally never used it in a case of acute severe ulcerative. And the only thing which we use after steroids would be infliximab, followed by surgery if patients would not improve. And of course, C-reactive protein dropping by 50% by 3 days is a good marker that we are doing well with our patients. I think there's another question about whether sclerosing cholangitis would affect the choice of treatment.
I thought you tried to evade my. I thought you tried to evade my question, but I'm glad you're circling back to it.
Yes, I know that you will insist to know the answer.
I was about to remind you.
I understand, but really, I could not really have a clear answer for this question. And I would like to hear what's your opinion, whether it would affect or not. But in my own experience, I don't think it would change my decision of what I have already said.
Yes, I agree with you, and I would be interested in Dr. Al-Babardi's opinion on that as well. Before I will ask Dr. Dugan about JAK inhibitors in acute severe ulcerative colitis. So there is a quite well organized study group that is driven from Europe about PSC, IBD, and medications. And they looked at infliximab, vedolizumab, tofacitinib, and all data, retrospective data, suggests it's safe to use in PSC. So I personally am not influenced, and I see Dr. Al-Bawardi nodding his head, but then I will hand it over to him for his opinion. But I personally do not worry about the PSC in that situation. Having said that, the studies that exist are usually relatively short-term. They follow surrogates like alkaline phosphatase change in transaminases. But from all we know, it appears to be a safe choice even in PSC. But Dr. Al-Bawardi, what do you think?
Well, I think when it comes to a PSC patient, we've done a recent systematic review meta-analysis also looking at advanced therapies in PSC IBD, which we will present at DDW. And we separated anti-TNF from non-anti-TNF biologics, just because there was one previous study that suggested anti-TNF biologics might have a higher risk of acute cholangitis. In our review, it did not seem that anti-TNF increased risk of cholangitis. So in a patient who does not have decompensated cirrhosis, I think any choice of those agents are appropriate, and we would probably want to avoid undertreating the disease because of fear of liver side effects. So I do agree. I think overall it should not affect the choice, but we should really tailor it towards the IBD part.
And actually, a good point that I did not mention is to separate decompensated patients, liver patients, from stable liver patients, which I actually didn't mention. It's a very good point. In this case, it's stable. So Dr. Cohen, if you could type your choice into the text box, and Dr. Dugan, before we move on with the case, where do we position JAK inhibitors in the treatment of acute severe colitis? And is there a role post-infliximab failure?
Just to mention, Dr. Dugan is a surgeon, so he's going to be with us for surgical input.
Oh, okay. Then I would.
You have Dr. Al-Amil, Turkey, is with us also. Turkey.
Excellent. So then I will ask Dr. Al-Amil, and then I will have a surgical question for Dr. Dugan. Thank you for pointing that out, Ala.
Yeah, thank you so much. So I think JAK inhibitors would probably have a role nowadays in managing patients with acute severe UC. We saw data from a randomized controlled trial done in Canada, presented in the ECHO last weekend, showing positive results. And the recent publication in the Red Journal, the TACOS trial, was an investigator-initiated study from India, showing positive effect for tofacitinib with corticosteroids in patients with acute severe UC. So I think we'll see more JAK inhibitors used in this indication in the future. And it's an attractive option since it's a small molecule. If the patient requires surgery, it will be out of the system in a relatively short period of time.
Very good. Yeah, and I agree with you, Dr. Cohen. Also agreed with the panel, 10 milligrams per kilogram infliximab as the first choice. And in the US, we only allowed to give JAK inhibitors as a second line in these patients. So I would ask for a surgical opinion, and then Dr. Al-Babardi can continue with the case. So Dr. Dugan, when you were involved very early in this fictional virtual case, the patient says, "I don't want to have surgery." How do you talk to the patient? What do you explain to them would happen with the colectomy, future options?
Thank you very much for. I really enjoy these IBD meetings. They are very enlightening, and we get to see a lot of very challenging cases. Can you hear me well?
Mm-hmm.
Yes. Yeah.
Yep.
I mean, the difficulty with these patients, especially when they are young, and then when you approach them about having to lose their colon, is to try to concentrate as much as possible on improving their quality of life. That's the most important. So I personally try to highlight about improving their quality of life, getting them out of the hospital, getting them back to add some weight, getting them back to get some energy to go back to their usual work. So this is essentially will be the cornerstone of my discussion with the patient in order to sway them towards surgery. I mean, when I looked at the X-rays of this patient and his presentation to the clinic, as presented by Dr. Agawadi, it is very clear that this guy personally would not have taken a lot of medical treatment. I think he would have failed anyway, and a rescue surgery would have been the ideal option. But the way I tackle them is essentially I concentrate on how important surgery will be to get them back to where they should be.
And would you do it in case the patient decides on surgery? What would your surgical approach be?
The approach is very simple. It's a 3-stage procedure. There is always the concern, as you've highlighted, about whether this is Crohn's or this is ulcerative colitis. So we go for a laparoscopic or an open subtotal colectomy, depending on where you are and the availability of the resources. But a subtotal colectomy. And I personally would do an end or perform an endoileostomy, and always have a mucus fistula available, because the mucus fistula is very important so that the patient does not get erectile stump blowout and deteriorate further. So that is essentially the rescue procedure for all the type of patient presenting.
Very good. So we have the surgeons on board now, and now Dr. Al-Bawardi will tell us what happened with the patient.
That discussion was really great. So moving on for this patient's hospitalization, before we go there, I thought this would be a good time or opportunity to just hopefully not spend too much time on this, but to review the literature on the rescue therapies. So I agree with what has been mentioned before, that when I use infliximab, I use it as 10 mg per kg. But just for knowing what the evidence out there is, and this is based on retrospective studies and meta-analysis of retrospective studies, not suggest the benefit of accelerated infliximab. But I want to emphasize these are retrospective, so they have confounding and bias. And when the meta-analysis also did not differentiate or did not find a difference between accelerated and regular dose infliximab in acute severe UC, it's important to note that patients who did get a 10 mg per kg versus 5 mg per kg tended to have a lower rate of colectomy. So without high quality evidence, I would still continue the practice of giving 10 mg per kg upfront for acute severe UC. And then, as mentioned before, we have 2 randomized clinical trials that compared cyclosporin and infliximab. The SISF study, which was an open randomized controlled trial, open label randomized controlled trial, and as you can see from the Kaplan-Meier curve, there was no difference or significant difference between the colectomy-free survival rates in infliximab versus cyclosporin, and the same can be said about the construct study. Now, I'm going to dive into the JAK inhibitors a bit, because I think this is where kind of we wanted to discuss more about the use of JAK inhibitors in acute severe UC. And the first kind of evidence that emerged was from the Michigan group, and this was a retrospective matched control study. And they did dose patients at 10 milligrams TID, and some patients did get the 10 milligram BID dose. And the reassuring thing is that there was no difference in adverse events, including VTEs. And then you can clearly see here, based on this retrospective study, that patients who got tofacitinib 10 milligrams TID were more likely to avoid colectomy versus those that got it BID or got the standard of care. And the same kind of idea was replicated in a prospective/retrospective study from France, where there was about 55 patients, but these patients were dosed at 10 milligrams PO/BID, and the colectomy-free survival was 85% after a median follow-up of 6.5 months. Now, one question that I had up there is, would you ever use or consider using a JAK inhibitor after infliximab failure? I think a word of caution has to be out there, is obviously we don't want to delay surgery for these patients. They could end up with more complications. And we don't really have a lot of evidence on this type of practice. In digging through the literature, the only thing I found was this small case series of 5 patients who got sequential tofacitinib after the failure of infliximab salvage. And overall, if you move to the right side of this table, you'll see that about 3 of these patients did well, meaning in terms of their clinical endoscopic outcomes, and only 1 patient ended up with a colectomy. As mentioned by Dr. Kalamir, I think the highest quality of evidence we have for tofacitinib in acute severe UC is the TACOS trial. And this was a randomized double-blind controlled trial, which used the 10 milligram PO/TID dosing versus placebo. And in this trial, they gave upfront tofacitinib in addition to IV corticosteroids for 7 days, and then assessed the outcomes after 7 days. And at 7 days, the corticosteroids were stopped. And as you can see here, the tofacitinib group, there was a higher proportion of patients in the dark gray who had response to therapy and lower need for rescue therapy. And then you can also see that the colectomy-free survival for the patients on the tofacitinib group was better. And then the newest JAK that we have approved is upadacitinib, and we are now seeing some case reports emerging on the utility of upadacitinib in acute severe UC. But the largest body of evidence is this recently published brief report. Again, it's a collaborative effort from multiple centers in the US, led by the Michigan group. And this was a small study. It was only 25 patients. Some got the traditional dose of 45 milligrams, but some got an accelerated dose of 30 milligrams of upadacitinib BID. And all these patients received IV corticosteroids first, and the primary outcome was 90-day colectomy. I reported the percentage here a little different than was reported in the study. I just took all of the patients and then looked at how many actually ended up with a colectomy after 90 days, and it was about 24%, which is in line with what we see sometimes with anti-TNFs or even cyclosporin. Now, there was no difference whether the patients were exposed to anti-TNF in the past, and there was no difference between the upadacitinib higher dose or the approved dose. However, the study is really too small and not powered to assess for those differences. And you can see the steroid-free clinical remission was about 60%. And most importantly, we want to look at adverse events. There was only one intra-abdominal post-op venous thrombosis. So this was a post-op patient. There were no post-surgical complications. And then there are 2 patients who had sequential upadacitinib after infliximab without complications. I understand maybe I'm running a little over, so I'm going to try to close up this case. So for this patient, we ended up giving infliximab 10 mg per kg. We actually gave a second dose, as Flo was saying. We kind of follow the same thing. When the CRP plateaus, we give a second dose. So we gave the second dose at 5 days later. The patient completed treatment for his CMV, and repeat CMV PCR was negative, but unfortunately he continued to be quite symptomatic, up to 9 bowel movements a day. The CRP still high at 60, and the infliximab level post the second dose was 18.9, which is actually a relatively sort of lower level. So obviously at this point, we definitely have to revisit the surgery discussion. The patient really deferred surgery and did not want to go that route. So we did discuss starting a JAK inhibitor post infliximab. We discussed the risks and benefit and proceeded with giving him 45 milligrams of upadacitinib. And within 1 week, he made some clinical and biochemical improvement and was discharged on a steroid taper with upadacitinib. So we gave him the extended induction dose of 45 milligrams for 16 weeks. And as you can see, he's clinically better. He's off steroids, but he still has biochemical inflammation. CRP is still high, the fecal cal still high, but his albumin normalized off corticosteroids, and his platelets showed reactive thrombocytosis. We eventually got him in for a colonoscopy, which was about 5 to 6 months after starting the upadacitinib, and it did show quite a bit of inflammation. This is the patulous IC valve you see on the right side. The terminal ileum had large ulcers, and you can see continuous and circumferential ulcerations throughout the colon. Again, discussed the surgery. Patient did not want to undergo surgery, and therefore we decided to do combination therapy. And this time we gave him ustekinumab, dose escalated to Q4 weeks with upadacitinib. And again, clinically, he was feeling well off of steroids, and now we're seeing that his inflammatory markers are trending downward. So his CRP was down to 24, and the calpro is finally less than 1,000. His albumin remained well, and his platelets are starting to trend downwards. We repeated colonoscopy about 6 months later, and now you can see a significant improvement in the inflammation. So now these large circumferential ulcerations have resolved. You can see there's still some small aphthous ulcers throughout the colon, but really a remarkable improvement, I think, overall. So our plan is to continue both combination therapy because he's not in complete endoscopic healing, and also because his inflammatory markers remain a little up, and some of the elevation in calpro could be related to the pseudopolyps we've seen there. What I'm worried about the most with this patient is his neoplasia risk, which is high. So we want him to stick with the annual colonoscopy and MRCP and CA19-9. Again, thank you again for the opportunity to present, and I really appreciate the discussion.
Yeah, thank you very much. An excellent presentation. A tough case because I think all of us would agree that the patient would benefit from surgery. Patient doesn't want surgery. And I was surprised to hear how well responded to the add-on of ustekinumab, because the anti-IL-23s, in my personal experience, are not the strongest medication for ulcerative colitis. They work very well in Crohn's disease, and I see a lot of head nodding, which there seems to be agreement between the panelists. And we need to, Dr. Ruggiero calls the colorectal surgeons colorectumab. So colorectumab should be part of the treatment paradigm early on in acute severe ulcerative colitis. And I think Dr. Dugan gave a really nice overview. One last question before we move on to the Crohn's disease case, as Dr. Malak is going to present from Dr. Sharara's team. Dr. Al-Bawardi, what about anticoagulation in these patients?
Right. So I'm glad you reminded me. I forgot to mention this. We actually consulted our colleagues in hematology. You know, the thrombocytosis is reactive, and we did actually some hypercoagulability workup on him, even though he does not have a high risk, even though he did not have a documented venous thromboembolism. And we actually ended up putting him on aspirin. We didn't put him on any anticoagulants, but this was in conjunction actually with the hematology consultation. I would agree, Flo. I would be concerned also about his risk of VTE with the active inflammation. And after consultation with the hematology, they thought aspirin would be appropriate prophylaxis.
Okay, yeah. What we usually do, and working with hematology is very good in that situation. We prophylactically anticoagulate the patients while they're in the hospital. Because of the high risk of VTE that you mentioned, even when they have blood in the stool, unless they are exsanguinating, we do a prophylactic anticoagulation.
Oh, yes. So inpatient, he was getting low molecular weight heparin, but outpatient, he was discharged on aspirin.
Okay, perfect. Yeah, perfect.
Yeah, definitely.
That's a good way of doing it. So thank you so much, and we're gonna come to the second case, and it's actually my mistake that we're going over, not yours, because I'm asking too many questions. So we're gonna go to the next case for Crohn's disease, and I'm looking forward to more discussions. Dr. Malak, we're looking forward to your presentation.
Okay, good evening, everyone. So this is a case of a 27-year-old male patient with history of Crohn's disease diagnosed in 2011. Initially, the patient was being managed at a different center. He had terminal ileal and perianal disease requiring multiple perianal surgeries. At the point, the patient was started on adalimumab. However, his perianal disease was still uncontrolled, so he underwent diverting transverse colostomy. Years later, in 2017, he developed antibodies to adalimumab, and the course was complicated by ileal fistula and abscess formation, necessitating an ileocecal resection. Post-op, the patient was started on vedolizumab, and he went into clinical and biochemical remission, and his colonoscopy showed a Rudgier score of I0, I1. Now, years later, the patient joined our residency program, and he started following up at our institution. He continued to be in remission and was doing very well up until 2021, when he had acute gastroenteritis with abdominal pain and diarrhea. Stool studies done, and they were positive for salmonella, and the patient was given a course of ciprofloxacin with improvement for a few days. But then he relapsed, and the patient developed chronic diarrhea with gradual severe weight loss up to 30 kilograms over a period of 6 to 9 months. So for the severe diarrhea, weight loss, and anemia, we initiated an extensive workup, starting with serology that showed significant iron deficiency anemia. He also showed signs of malabsorption with low vitamins and low albumin. Stool studies were also taken, including C. diff, and they were negative. The patient had a normal CRP with a calprotectin of 104. We also took HIV test, and it was negative. We did also an MRE, which was completely normal. But what was significant was the remarkable 24-hour fecal fat that was high, around 13 grams. So we decided to proceed with EGD and push enteroscopy, which were negative with a normal small bowel biopsies. Colonoscopy was also done via the transverse colostomy and per anus, and we could see a stricture with erythema and minor ulceration at the ileocecal anastomosis. It could not be crossed with the scope, and so the patient successively underwent balloon dilatation. Now, to note, proximal to the dilated stricture, the terminal ileal mucosa was completely normal, and the examination of the diverted colonic segment was negative with the cetons seen in place, as you can see in the third picture. So with the ongoing diarrhea and extensive negative workup, we went through again all the common causes of steatorrhea, taking into consideration pancreatic insufficiency, bile salt-related diarrhea, particularly in small bowel Crohn's disease, bacterial overgrowth, and surgical resection of the ileum, especially when the segment is long. We also did not forget about impaired intestinal surface epithelium, such as the celiac disease, AIDS, and giardiasis. We also thought about, even though rare, other causes such as Whipple disease, Zollinger-Ellison, and the medication-induced diarrhea. However, as you can see, patient failed to respond to multiple lines of treatment. He failed to respond to loperamide. He had no response to pancreatic enzymes. He also had no response to bile acid sequestrants, and even a trial of high-dose rifaximin for possible SIBO failed to control his symptoms. The patient also had no response to a course of ciprofloxacin and metronidazole. So in this case, in this extensive negative workup and ongoing diarrhea, what should be the best next step? And I will pass it here on to the panel to run the medical discussion.
Yeah, thank you very much for the presentation. I'm going to start the case with a question for the surgeon before I will go to Dr. Mogaber. I'm going to ask Dr. Mogaber about what do you do in a Crohn's or IBD patient that in this scenario is not directly reflected in the case. The case is more complex. But a patient that's in remission still has diarrhea. What's the differential in a patient like this? I will ask Dr. Mogaber. But let me start with Dr. Dugan. So in what instances do you put a transverse colostomy versus an ileostomy in a patient with ileal disease and perianal disease? And what would be your decision making?
A very, very complex question, I have to say. I think most of the time when we face patients with complex Crohn's disease, whether specific to the to ileal disease or to ileocolonic disease with perianal disease, we consider the colostomy when we have very bad uncontrolled perianal disease that we need to work on their quality of life. We unfortunately still see these young patients who struggle with very bad perianal disease, and we're unable to control their local symptoms with just draining cetones when repeated surgeries. So sometimes we believe that by diverting the stool to a colostomy, they might get better control in terms of their quality of life. Why don't we go and convert to an ileostomy is because we prefer the colostomy as a better form of diversion. We believe that you always have this long colonic reservoir that will continue to shed more and more problems for their perianal symptoms. And that's why we prefer a colostomy rather than an ileostomy.
Okay. And then what was interesting, and thank you for explaining, what was interesting to me is then even at the time of the ileocecal resection, the colostomy stayed in place rather than doing ileocecal resection, ileocolonic anastomosis. And that was quite interesting. And then I have a question to Dr. Sharara, and that's an honest question that I don't know the answer to. How do you interpret fecal fat in the presence of a colostomy? Is that any different than regular stool fecal fat?
Yeah, that's a good question. I don't know the answer to it, but my guess would be that usually there's no fat absorption in the colon. So I don't think it matters really.
They probably should. Probably you're right. Probably it should not matter. I did not have a case consideration like this before, but it is an interesting case, and there will be a nice twist coming soon. So Dr. Mogaber, one I think interesting learning part of this case is if you have a IBD patient that continues to have symptoms, diarrhea, weight loss, abdominal cramping, doesn't have active disease, what is your differential? So we saw in the other medications that have been tried, loperamide, pancreatic enzymes, bile acid sequestrants. So what is your differential in a patient like this? And how do you try to treat that patient in your practice?
Yes, these patients are usually in a very bad condition. And as I heard and I saw the presentation from Dr. Sharara's side, there is a big list of differential diagnoses. And the problem is in order to reach a definite diagnosis, you may need to go through this list of long workup until you finally reach the definite reason why this patient has a malabsorption, and whether there are blind loops following surgery, whether there is a reason for it, if it's biliary or whatever the reason is, and accordingly you can manage. But for this moment, I think the most important step is that we should nutritionally support the patient, and I think this would be the main stand. What's next is the question. I think it would be nutritional support, and I think it should be a combination of enteral and parenteral nutrition. And then we do the workup to reach a definite diagnosis, which may help us in improving the situation of these morbid patients. These are some kind of patients which I think are the most difficult patients to manage and treat, but nutrition support and nutritionist role is the most important part in such a patient.
So
did I bypass the question, or?
No, you did not. No one escapes my questions. So
no one can. They're doing it.
Very good. So Dr. Al-Bawardi, what will be your next steps?
Definitely a tough case, but if I look at what the patient's at risk for, so he's had an ileocolonic resection and has a stricture at the anastomosis, definitely small intestinal bacterial overgrowth. He's at a very high risk of that. That would give you steatorrhea. That would give you malabsorption. So, but I understand he was given a course of antibiotic empirically without improvement. So in my mind, there are two other places to look for. It's, the pancreas or the rest of the small bowel. So I want to see if the pancreas was evaluated structurally by cross-sectional imaging. And the other thing is, I definitely want to look at the rest of the small bowel, so an enterography. And what I'm looking for is, there is a change in clinical status here. There's a new onset anemia, there's malabsorption. Does he have any lesions in the small bowel? Particularly, he's had small bowel Crohn's for a long time. I can't remember if he was on thiopurines for a long time in the past or not, but to look for malignancies such as lymphoma, for example, or small bowel adenocarcinoma. So I would look in the small bowel and the pancreas structurally.
Excellent, because what I tried to elicit from the panel is exactly the imaging point, because I think that has not been mentioned, to get an enterography, because the patient may have disease higher up than where we can get with our endoscopy through the colostomy. So very good points. Before I ask the case to continue, I would like to hand it over to Dr. Kotubi. So the patient was on adalimumab initially with perianal disease. Seems to be a good choice. Then developed antibodies. Next choice after the surgery was vedolizumab. Is that something you would have also chosen in a situation?
Well, I'll go back just for a second. We had a very similar case where we actually struggled with, and we had to do an enterography and took multiple biopsy from the small bowel. Now, our patient had a small bowel disease actually, and autoimmune disease, and later on did very well with biologics. So again, as you mentioned, Florian, small bowel is the key in this case. Now, to answer your questions, I don't know. I personally, I will not go for adalimumab to start with in perianal disease. I think it is, in my experience, is inferior to the infliximab. So usually we go with infliximab higher than, much better choice compared to the adalimumab. But anyway, this patient did well and developed antibody. I personally will not go with Vido, because Vido will not work much, based on the studies after anti-TNF. So usually we'll go with other options like any of the interleukin. You can use either the Stelara or Skyrizi, or you can use any of the JAK. But I will not. Let me put it this way: it is not my favorite to go with the Vido after anti-TNF.
Yeah, and I probably in our center we would have probably chosen ustekinumab afterwards. After surgically induced remission, vedolizumab may actually be a reasonable option. However, patients still with perianal disease. And then you could argue there is randomized data. It was the 2 different doses of vedolizumab in patients with perianal disease. It does work in perianal disease also, but I probably would have chosen ustekinumab, risankizumab, or INT'L 23. So very good discussion again, and then I will ask Dr. Malak to continue and provide the twist of the case.
So with this ongoing diarrhea and extensive negative workup, we suspected cystoisosporiasis. This is why we decided to send again stool studies, but this time we asked for a special stain, which is the modified quinine acid fast stain, and we were able to detect Isospora belli. The patient was started on a course of trimethoprim sulfamethoxazole for 7 to 10 days, and on day 3, the diarrhea resolved. The patient was again able to regain all the weight loss, anemia and vitamin deficiency resolved. He was back to his normal activity and re-established his energy levels. So I'm going to talk briefly about cystoisosporiasis. As we know, Cystoisospora belli is a cosmopolitan coccidian unicellular protozoan, like other enteric pathogens such as Cryptosporidium and Cyclospora, that primarily infects the intestinal epithelium. Now, although it's commonly seen in tropical and subtropical regions, as you can see on this map, Isospora belli can have a worldwide distribution, and it can be even seen in high-income countries. Now, we have to remember that this is an opportunistic pathogen responsible for up to 14% of cases of diarrhea in HIV-positive patients, and having a low CD4 count less than 150 is a main risk factor. So for the life cycle, we know that humans are the only known host for Isospora belli, which has no known animal reservoir, and the transmission is via the fecal-oral route from intake of contaminated or polluted food or water. After ingestion, the parasite invades the enterocytes in the small intestine, and the parasite completes its life cycle within the human host, and immature oocysts are then excreted in stools 9 to 17 days after the infection. Now, though cystoisosporiasis is known to occur in HIV patients, reports in the literature showed that it can infect immune-competent hosts as well as patients with cellular immune deficiencies such as lymphoma, leukemia, transparent recipient patients, and patients on immunomodulators such as anti-TNF. In the literature, there is only one case report from Germany, actually, where we saw Isospora belli in a patient with UC who was treated with infliximab and azathioprine. She had a stable disease, but suddenly developed watery diarrhea, and they were able to detect Isospora belli oocyst when taking stool studies with the acid-fast stain. Patient was treated with trimethoprim sulfamethoxazole, and she responded well clinically as well as microbiologically.
If it's from Germany, it must be very good quality.
Yeah. Definitely.
Just kidding.
Concerning the clinical manifestations, as we said earlier, the patient will manifest as watery diarrhea, weight loss, abdominal pain, and vomiting. Now for the diagnosis, usually it is made by detecting the oocysts in feces. However, we have to remember that oocysts are often excreted intermittently, and this might be sparse, which makes the diagnosis difficult. So multiple specimens are usually needed for a good diagnostic yield. And in a study, it seemed that the sensitivity can be increased up to 100% with 4 consecutive stool tests. Now, remember that PMNs are not observed in fecal specimens, like the case of our patient. And you need to remember to ask for special stains, such as the acid-fast, the fluorescent stain, and even a modified Ziehl-Neelsen stain. Isospora is often missed because the specific stains are not ordered by physicians most of the time. Now, concerning the treatment, the typical treatment regimen for adults consists of trimethoprim sulfamethoxazole, double-dose strength, twice daily for 7 to 10 days. And it will result in cessation of the diarrhea or a decrease in the diarrhea and the abdominal pain on day 3, like what happened with our patient. In patients who are intolerant to sulfonamides, you can try pyrimethamine in combination with folinic acid. Ciprofloxacin has been described in the literature as treatment for cystoisosporiasis. However, it is less effective than trimethoprim sulfamethoxazole, and I remind you that our patient tried the course of ciprofloxacin with no improvement. Now, when we have an effective treatment, stool samples examined after 10 days usually should not contain the oocyst. So, our case did not end here. So even after the treatment, the patient remained well, but after a while, he had forced non-compliance with vedolizumab due to access issues. And few months ago, he developed right inguinal pain that was initially attributed to exercise. But 2 days later, he presented to the ER with a right inguinal bulge and pain, and his CRP was elevated. We did a CT scan that showed actually a small organizing 3 by 3 centimeter collection along the anterior abdominal wall muscle with suspicion of an intercutaneous fistulous tract. So we can see here in the first image at the yellow arrow thickening and inflammation at the iliocolonic anastomosis. In the second picture, we can appreciate soft tissue thickening at the right iliac fossa. And when we gave contrast, we did contrast opacification by retrograde giving contrast through the colostomy. Here we're able to also appreciate a stricture at the iliocolonic anastomosis with thickening at the anterior abdominal wall in communication with an inflamed bowel loop. So the patient had a percutaneous incision and drainage of a right inguinal abdominal wall abscess. The incision initially drained small amount of pus, but we had no stools or bile. He was discharged on Augmentin 1 gram BID. But 1 week later, the wound did not close and the patient still had persistent small amount of fluid drainage from the incision site. His CRP trended down, and so we decided to go for MR enterography. And as you can see highlighted in red, we saw on the MR enterography an abscess in communication with an inflamed anastomosis. And here we decided to go for colonoscopy. So when we did the colonoscopy at the anastomosis, we saw localized ulceration and stricture that could not be crossed with the scope, as you can see in the first image. We used a gastroscopy, which was able to dilate the stricture, revealing a short segment of ulcerated edematous area, 1 to 2 centimeters in length, with completely normal proximal terminal ileum, as you can see in the last picture, up to 20 centimeters. So we are dealing with a fistulizing Crohn's disease, post-diverting transverse colostomy and ileocecal resection with a short ulcerated anastomotic stricture and probably low output fistula. So what should be done next in this case? And here I will pass it on to the panel to discuss the best possible option.
Wow, so very, very difficult case. And I want to be conscious of the time because we have like about 3 minutes left. But I'm going to call on 2 panelists before we close the session today. So I'm going to first ask Dr. Dugan, is this now time for total proctocolectomy and ileostomy in this patient, given the fistula, the stricture, transverse colostomy, and fracture perianal disease? And then Dr. Al-Amil to briefly comment, is there room for medical therapy and what would it be? So Dr. Dugan, please.
Well, again, we face a very, very complex situation. The problem now, we have a diseased ileocolic anastomosis fistulizing to the outside and a patient who has bad perianal disease. I think the option that you have highlighted is very true. I think the best option would be to consider a panproctocolectomy and an ileostomy. If the other possibility is really to resect everything, including the perianal area, with the help of the reconstructive surgeons, and that patient will finish from all his troubles but he has to accept to have an ileostomy for life. The problem is we have now multiple failures in his intestinal tract, the anastomosis, the colostomy that needs to divert his perianal disease, and his perianal disease, which has definitely an impact on the integrity of his pelvic floor muscles. So I would agree a panproctocolectomy would be the best option.
Mm-hmm. Dr. Al-Amil, do you agree, or you think we should try more medications? And then if you agree with surgery, the patient says, I don't want to have surgery, which therapy would you choose?
Yeah, I think just to be brief, I think ideally you would go for surgery, and instead of looking at it as either or, I would do both. So surgery and put the patient on medical therapy postoperatively to prevent recurrence. A reinduction with vedolizumab, the preview trial showed that vedolizumab is effective in patients with surgically induced remission. However, I don't think they had patients with fistulizing disease. I like the idea of combining of infliximab with methotrexate. This was done in the COMMIT trial. This is a young man who's at risk for lymphoma with thiopurines. I think newer agents, R23, 1223, and JAK inhibitors have not shown a clear effect in fistulizing disease in a case similar to what we're looking at. Now, whether we should combine advanced therapies, that's probably a bit difficult to judge. And with the access issue where he is residing now, I think it's better to stick with infliximab and methotrexate for the time being, rather than risking putting him on a medication that we may not get in the future.
Yeah, and I agree. So these strictures, and then we're gonna wrap up. So if you have a stricture with an enterocutaneous fistula upstream of it, they don't respond to medical therapy, and there's fairly good data that very, very hard to treat. So I do think surgery is critical to convince the patient to undergo surgery. And if undergoing surgery, given that still perianal disease despite transverse colostomy and medical therapy, the likelihood that this is gonna heal is low. So I personally, and I agree with our surgical colleague, I would probably talk to the patient about a permanent endometriostomy and proctocolectomy. If the patient does not want that, I agree with infliximab, methotrexate, or upadacitinib as an alternative would probably be my choices, but it is a very hard to treat patient. And Dr. Malak, excellent presentation. It was a really complicated cases, and thank you everyone for their input. Thanks everyone for joining. And I'm gonna give the last words to the boss, Dr. Sharara.
All right, well, thank you, Flo, for moderating both cases. I thought they went really well, both difficult cases with twists in them. And I would like to thank the panelists and the audience for attending. And we'll look forward to see you all again in a couple of months with a couple of more exciting cases. So thank you.
And then Dr. Cohen will be back with us, and he sends his regards. He was not able to participate because of his voice, but he was participating via chat box.
Thank you so much. See you soon.
Thank you.
Thank you.